Today we are going to start with the last portion जो हमने ख़त्म करना है parasitology का, and today would be the last lecture for parasitology. तो आपका parasitology का course जो है that would be finished. और next week से we will start with the mycology. Again it's a short course. और अब पैरासाइटोलॉजी आपने फिनिश कर लिए. नेक्स्ट टेस्ट आपका हीमोडायनामिक्स पे, और हीमोडायनामिक्स के बाद आपका पैरासाइटोलॉजी का टेस्ट आएगा. बट आई वुड सजेस्ट कि आप दिन में सिर्फ आधा घंटा निकाल के, नॉट मोर देन 30 मिनट्स, आप आधा घंटा निकाल के अपनी पैरासाइटोलॉजी पढ़ना शुरू कर दो. एंड जस्ट डू वन पैरासाइट एट अ टाइम. और अगर आप आधा घंटा निकाल के थोड़ा थोड़ा करना शुरू कर दो कि जितना भी आधे 45 मिनट्स, 30 मिनट्स टू 45, 30 मिनट्स मीन्स 30 मिनट्स स्टडी टाइम. 30 मिनट्स डज नॉट मीन कि आपने अभी किताब खोली है, उसके बाद पेजेस निकाले हैं, फिर उसके बाद सेट किया अपने आप को और उसी में आपने 15 मिनट निकाल दिए, फिर 15 मिनट आपने नहीं पढ़ना. आई मीन 30 मिनट्स ऑफ सॉलिड स्टडी. और उसमें अगर आप एक एक करके, एक एक या दो दो करके आप करना शुरू करोगे, और साथ ही में उनके, जैसे मैंने आपसे कहा था कि टैबुलेटेड फॉर्म में उनकी पॉइंट्स जो है वो आप लिखना शुरू कर दोगे, तो बाय द टाइम आपका टेस्ट आएगा एट द एंड ऑफ दिस मंथ, तो आप जो है वो यू वुड बी वेल प्रिपेयर्ड फॉर पैरासाइटोलॉजी. क्योंकि जो आपके अब अगले फ्यू टेस्ट आने हैं, आई थिंक लेट मी चेक, दे आर गोइंग टू बी, आपका हीमोडायनामिक्स का टेस्ट आना है, वायरोलॉजी का आपका हो गया, हीमोडायनामिक्स का आपका, हीमोडायनामिक्स के टेस्ट में और पैरासाइटोलॉजी के टेस्ट में देयर इज हार्डली अ वीक. सिमिलरली पैरासाइटोलॉजी और माइकोलॉजी के टेस्ट में भी आपका वीक टू 10 days है. So between hemodynamics and parasitology, you've just got a week. So which means ke yes, first we've got hemodynamics, and then within a week's time, 22nd को शायद hemodynamics है, 29th को parasitology है, and then around the 10th 12th I think probably of August you will have mycology. So hemodynamics और parasitology में आपके पास सिर्फ एक हफ्ता है. So give maximum time to hemodynamics, and as I'm telling you, आप parasitology को साथ साथ थोड़ा थोड़ा रोज रोज पढ़ना शुरू कर दो, so that by the time आपका parasitology का टेस्ट आता है, you would be well prepared. और उस वक्त फिर एक या दो दिन में जो आपके पास एक हफ्ता होगा, that would be more than enough to go over it at least twice, and then you will be well prepared with the test. ठीक है? So let's start with today's if you have any questions, you can ask here, you can ask me on the Facebook page. और किसी चीज़ की आपको टेबल चाहिए, किसी चीज़ का आपको डायग्नोसिस चाहिए, किसी भी चीज़ की आपको कोई भी एक्सप्लेनेशन चाहिए, यू नो यू आर ऑलवेज, आई हैव ऑलवेज एनकरेज्ड यू, और आप लोगों को मैं बार बार कहती हूँ कि put up your questions and I will answer them, no matter how simple those questions are or how easy those questions are. It doesn't matter. सबसे बड़ी बात यह है कि अगर आपको कुछ चीज समझ नहीं आ रही, तो you should ask questions and you should clarify, so that in future आपको उसमें कोई problem ही ना हो. That is why when you don't clarify your points, तो उस वक्त आपकी जो SCQs की answers हैं या MCQs की वो जो answers हैं, they are because your points, you are not clear in your mind, you cannot answer them well. So let's start with today's lecture, and as previously we had started with the nematode, which was Strongyloides stercoralis, and as this was the smallest nematode we were talking about, so it's also known as the dwarf worm, and since it is a thin like structure, it was also called the threadworm. Geographical distribution, majority of these they have a worldwide distribution with warm humid climate and location. We saw that the adult was in the duodenum and the jejunum, and the transmission was not through the fecal oral route. It was by the skin contact with the contaminated soil. So went into the skin, and then it started its further journey from there. And the definitive host was man, and there was no intermediate host. So, and the eggs they were found in a row within the adult female worms, and these eggs, if you remember, they hatched within the epithelium of the intestinal wall, and from there the larvae were liberated, and these larvae then came out into the fecal matter, and they were passed out into the feces. So it was the larvae and not the eggs which you are going to look for in the diagnosis. There are two types of larvae. One is the rhabditiform larva, and the other is the. I hope there is no issue with the audio. Okay, so we have the rhabditiform larva, and then we have the filariform larva, and the rhabditiform is smaller, the filariform is larger, and we were discussing these two forms last time when we stopped with the lecture. The larvae are The larvae are two in types, rhabditiform and the filariform. Remember, the filariform larva is the infective form, and you can easily remember this by if you remember the F's. Filariform starts with an F, and infective, it has an F in it. So remember that whenever you are asked in which type of larvae they are going to be infective, it is not just for this parasite, for the other parasites as well. It is always the filariform larva which is going to be infective, and not the rhabditiform larva. So the rhabditiform larva has to convert itself into the filariform larva before it can cause any infection. This rhabditiform larva is going to convert in different ways. It can either directly change from a rhabditiform larva into an filariform larva within the lumen of the intestine, and this is known as internal reinfection. And then these filariform larvae, they will be passed out into the fecal matter, and when they come into contact, they are then going to infect the skin, or they can be passed out into the feces, and they can penetrate the perianal area and then cause an auto infection, or they can penetrate the intestinal epithelium. So within the lumen, they are going to convert directly into the from the rhabditiform into the filariform larva. Each rhabditiform larva will convert into a filariform larva, and there are three different ways when they are going to they can cause either they can cause an internal reinfection within the intestines. They will stay there, from there they go back into the intestinal epithelium, or they can pass out into the fecal matter, and into the fecal from the fecal matter, some of which will get attached to the anal area, perianal area, and from there they can just go back into the intestines and then cause an auto infection. Then the third is that they are going to be passed out into the fecal matter. And these rhabditiform larvae, when they are passed out into the fecal matter, they are going to go through two different types of cycles for development in the soil. Number one is the direct cycle, and number two is the indirect cycle. Direct cycle, within 3 to 4 days, each rhabditiform larva is going to convert itself into a filariform larva directly. There is no in between sexual cycle, no phase, so sexual phase in that case. In this situation, each rhabditiform larva is going to produce one filariform larva. And then there is the indirect cycle, which is actually responsible for the propagation or for the spread of this parasite in the environment and the community. So if only one rhabditiform larva converted into one filariform larva, then the infection would be limited to a certain extent. But when they go through the indirect cycle, each rhabditiform larva within 20 to 24 to 30 hours converts into a generation of male and female worms. This rhabditiform larva will produce adult males and adult females, both of them sorry, both of them, they are then going to mate, and they are going to produce a second batch of rhabditiform larva in the soil. The first was produced in the intestines of the humans, and the second is going to be produced in the soil, and then these second batch of rhabditiform larvae will convert into the filariform larva. And the second batch of rhabditiform larva is generally about 25 to 30 filariform larvae, which they are going to be produced by the mating of the female and the male generation within the soil. And this is going to result in the formation of a huge number of filariform larvae as compared to the direct cycle, and therefore each filariform larva is able to infect a human being. And so over here, through the direct cycle, one filariform larva, one human being is going to be affected. In the indirect cycle, one rhabditiform larva is going to produce 30 filariform larvae, which are going to be then responsible for infecting 30 different people. So this is how it tends to spread in the community, and to produce massive infections. This is the life cycle, and the life cycle is very simple. We go through this is the larval form. Let's start from here. The rhabditiform larvae, they are excreted in the intestine. Then they are going to produce these mates, and these are then going to produce these eggs, and these are then going to produce the rhabditiform larvae. And these rhabditiform larvae can also give rise to more generation of adults, and the cycle is going to continue, and the rhabditiform larvae will convert into the infectiform larvae, and this rhabditiform larva will also convert into the infectiform larvae, and these will then be and penetrate the intact skin, and this will initiate the infection. And from the skin, they are going to go into the circulatory system. From the circulatory system, from the circulation, they'll pass to the lungs, and then they are going to penetrate the alveolar spaces, go into the bronchioles, then the bronchi, then they go to the throat, then down the throat into the esophagus, and then they come back into the small intestine. And over here, they're going to become the adult male and females. Then the adult females, they are going to go into the intestinal epithelium, where they are going to deposit the eggs. The eggs are going to hatch, and they are going to migrate into the lumen, and these are then going to be passed out. And then we talked about the auto-infection as well. Pathology, there were three stages. Number one was the invasion of the larvae into the skin, and at the site it will produce a hemorrhage, it can produce a swelling, itching, or inflammation. And then there was the pulmonary stage, during which it is migrating, the larvae are migrating through the lungs, so it can produce an asthma, it can produce a bronchial pneumonia, it can produce a non-productive cough, or it can, due to its movement, can cause a burning sensation in the chest. In the intestines, they are migrating randomly, and this is going to, and they are causing the deposition of the eggs, and this is going to cause abdominal pain, diarrhea, and burning sensations. Diagnosis: non-specific tests include the eosinophilia, which is 10 to 25%, and a serum IgE antibody, which represents the eosinophilia, is going to be increased in about, high levels are going to be seen in 50% of the patients. Stool examination is going to, we can carry out a direct wet smear examination, and this is going to diagnose, and the diagnostic feature would be the presence of the rhabditiform larvae in the stool. And remember, it is the rhabditiform larvae which are going to be seen in the fecal matter, and we have to distinguish them from another parasite which is very common, and that is the hookworm, or the Ankylostoma duodenale. Then the stool culture we can do for the filariform larvae, which will develop from the rhabditiform larvae, and then there is the duodenal aspiration, histological examination, and immunodiagnosis for the presence of these parasites in the body. Next, we come on to the another important and common infection in our area, and that is the Ankylostomiasis, or which is caused by the Ankylostoma duodenale, and this is also known as the hookworm infection. And this is also very common in children in our region. Then the family is the known as the hookworms, and they are the second most common helminthic infection, especially after Ascariasis, and they are going to be found especially in children. Then the habitat of the adult worms is in small intestine, where they attach themselves to the mucosa, and they are then going to suck on the blood and the tissue fluids. And this is because of the buccal cavity, which is very characteristic in the hookworms, and because of which it got the name of a hookworm, because the buccal cavity has cutting plates and teeth. So by means of these cutting plates and teeth, it gets attached to the mucosa, intestinal mucosa, and then it just sits there and it starts sucking on the blood, and it is going to cause a lot of blood loss and resulting anemia. Two species which are important, Ankylostoma duodenale and Necatar americanus. Both of them, they are similar except for a few morphological features, and these morphological features will help to identify, differentiate between the two. We are going to just study Ankylostoma duodenale, and they basically have a different geographical distribution. And then there are two different species, then Ankylostoma brasiliensis and caninum, and this causes a disease which is known as a creeping eruption. We'll discuss it in a little bit, but basically remember that these are pathogenic to human beings and these are non-pathogenic to human beings. They do not cause disease. Ankylostoma brasiliensis and caninum, they do not cause disease in human beings. Caninum is in dogs. So they do not cause disease in human beings, but these two, they cause disease in human beings, and most important is the ankylostoma. Any questions till this point? Geographically, worldwide, tropics, subtropics, and both of them, they are found in the Africa, Asia, and America. But as I said, Neketa is more common in the West, in America and Australia, whereas duodenale and Calostoma duodenale is found in the Middle East, North Africa, Europe, and in Asia. The hookworm disease depends upon the difference between the disease and infection will depend upon the number of worms they are present, as well as the nutritional status of the host. So less than 25 worms in certain individuals will produce no symptoms. In others, 25 to 100 may produce a mild symptoms, whereas more than 1,000 may produce a lot of complications, which may even lead to the death of that individual. Morphologically, remember that Ankylostoma duodenale adult males and females, they are longer and as compared to the Necata. And number two most important difference is between is of the buccal capsule. In case of Ankylostoma, they have elongated teeth, whereas in case it's an elongated cavity and they have teeth. Whereas is in case of Necata, the buccal capsule is spherical and it has cutting plates. So these are the morphological differences between the two. Rest is the same. Adults, anterior end is bent in the form of a hook, and the male anterior end is straight. Posterior end is also straight. The posterior end, in case of the female, it is curved, slightly curved, and it has 6 teeth in its buccal cavity. These are the 4 teeth-like structures, and then there are 2 knob-like structures on the dorsal surface. These are the hookworm. Again, hookworm is going to produce the larvae, and both the filariform as well as the rabbitiform larvae. So these are the filariform larvae in case of the hookworms. Coming to the life cycle, this larval form, this ankylostoma, it is going to, although it is producing the larvae, but it is going to, the adults in the intestine, they are going to pass down the eggs. So these are the eggs which you will be able to diagnose, which form the diagnostic feature in case of, the diagnostic feature in case of the diagnosis of Ankylostoma duodenale. So they have multiple egg-like structures within them, and they are oval in shape, oval in character. From these eggs in the soil, they are going to hatch. They are going to pass through various developmental stages, producing the filariform larvae. These filariform larvae, they are going to penetrate the skin. From the skin, they are going to go into the circulation. From the circulation, they are going to go into the lungs. Again, the same life cycle. It's going to go into the lungs. In the lungs, they are going to go into the alveolar spaces. From the alveolar spaces, they are going to go into the bronchioles and the bronchus. up the trachea, down the esophagus, into the intestines. And when they reach the small intestine, they are going to produce the adult males and females, which are going to mate, and the eggs are going to be laid, and the cell life cycle restarts again. So eggs, they are shed in the fecal matter, and they are usually at the 4-cell stage, and the females can release up to 10,000 to 30,000 eggs per day. And when these are passed out into the environment, these eggs can rapidly develop into the J1 larvae. The first stage larva is called the J1 larvae in case of the Ankylostoma, and this can occur within 1 to 2 days if the conditions of temperature and moisture, they are optimal. And then within the span of another few days, they are going to molt twice, and they are going to produce the J3 larvae. So eggs are going to develop into the first stage larva, which is known as the J1. Then the J1 is going to go through certain developmental stages, and which is called as molting, and it is going to produce the J2 larva, and then the J2 larva is going to again molt, and it is going to produce the J3 larvas. So the eggs up to the J3 larva, they are going to be produced within the environment in the soil. Then these larvae, they are going to penetrate the skin, usually of the hands, feet, and the buttocks, which are going to come in. These are the areas which generally come into contact with the soil. And then they are going to enter into the circulation. They are going to travel to the lungs, and within the lungs, they are going to produce the J4 larva and the J5 larvas. And then they are going to be cuffed up, going to the intestines, where they're going to molt again, and the adults will be produced. Just remember how many moltings and where these moltings are taking place, because that is an important part of the life cycle of these parasites. So you just need to remember 3 moltings take place within the eggs hatch into the J1 larva, and then 2 moltings takes place within the soil, and then another takes place in the 2 takes place in the lungs, and then 1 takes place in the intestines. Coming to the pathogenesis, the first symptom would be the ground itch, and this is the site at which the larva penetrates the skin. So it is going to produce a localized dermatitis over there, and there will be a lot of, because of the toxins or the antigens of the larva penetrating the skin at that area, which are being released, the antigens which are going to be shed at that point, it can cause a severe itching. Then as the larva is going to migrate, it is going to produce various signs and symptoms. When it reaches the lungs and it is molting, it is changing, it's shedding off its outer skin, and it is producing a new skin. So this skin is going to be the source of infection, or sorry, it is going to be the source of antigens for the human person, and therefore an immune response is going to be produced, and that is going to produce a localized hypersensitivity reaction at that area. And this is going to mimic a pneumonia, because it's a hypersensitivity reaction. It is causing an irritation in the lungs. There will be coughing, there will be inflammation at that area, and this can produce a picture which is similar to that of pneumonia. Then there can be mechanical damage when the adults are going to be produced. When these adults, they attach to the mucosa, they are going to do so with the help of the teeth in their buccal cavity, and they start feeding on the blood. A single worm, when it gets attached to the intestinal mucosa, it can take up to 0.3 ml of blood per day. It can suck up to 0.3 ml of blood per day, and as an individual can lose as much as 200 ml per day, because there's not just one parasite which is going feeding on the intestinal mucosa. There are a larger number, because there's not just one adult female which is attached to the intestinal mucosa. Generally they are more, and so if you have a accumulation, if you calculate everything, then the blood loss can be as much as 200 ml per day, and therefore the anemia develops very rapidly in such individuals. Symptoms may abdominal pain, general lethargy or weakness or laziness, and their loss of appetite. Coming to the lab diagnosis, again, 2 types of diagnosis: indirect and direct evidence. In the indirect evidence, we have the crystals in the stool. The blood could be positive for occult means जो आपको नजर नहीं आ रहा. So when the lab gets a stool sample and they examine the fecal matter for the presence of blood with the help of the naked eye, they are not able to see any blood in the stool. But when they carry out a chemical test, that chemical test reacts with any blood which is present even in minute quantities within the stool sample, and it gives a positive result. So since the blood was hidden, therefore this is known as an occult blood test. Occult का इंग्लिश में मतलब occult is an English word, and it means hidden या छुपा हुआ. So it cannot be seen with the naked eye, but when you carry out a chemical test, you can detect the presence of the blood in the stool. So generally, in case of ankylostoma, you will find a occult blood positive. Then when you carry out the peripheral blood examination, when you make a slide with the when you make a blood film with the peripheral blood, then and you look at the RBCs, you will be seeing a microcytic hypochromic anemia. When you carry out the differential leukocyte count in such individuals, again the eosinophils would be raised, and because there is a rapid turnover of the RBCs in case of the ankylostoma duodenale because of the microcytic hypochromic anemia. Therefore, reticulocytes or the early stage of the RBCs will also be present in large numbers. So we say that reticulocytosis is present. Direct evidence is the identification of the eggs in the stool, and this is the most common method for diagnosing the hookworm infection. When a child comes to you, you see that the child is anemic, and there is a history of loss of appetite, laziness, and general not well-being. So in that case, you advise most of the time. First thing which you advise is a stool examination for the presence of the worms. So it could either be this, or it could be and if there is anemia, marked anemia, it's more likely to be ankylostoma as compared to ascaris. Then you can demonstrate the eggs in the duodenal aspirate. You can do gastroscopy, can take out some duodenal aspirate, and you can demonstrate either the eggs or the adult worms in the duodenal aspirate. Similarly, adult worms may sometimes be passed out into the stool, and they can be identified. Now, we at the start of the lecture, I said there were two species of ankylostoma which were non-pathogenic to humans. So these are the Ankylostoma brasiliensis and the Ankylostoma caninum. They can invade the animals, and they basically produce a disease in animals, and they generally do not produce a disease in humans, but at times they can penetrate the human skin and cause parasitic infection in humans as well. But since in these two species, they are not human pathogens, so they can penetrate the skin, but they do not develop any further. So what I mean to say is that although Ankylostoma brasiliensis and caninum, they are animal pathogens, they will produce a full-blown disease in animals like Ankylostoma duodenale produces in human beings. But at times, they can also penetrate the human skins. It's they don't differentiate between animal and human skin. So if they come into a contact with the human skin, they can penetrate that as well. But afterwards, they are unable to proceed any further because they are not familiar, they are not pathogens for the humans. So they are just going to wander about at the site, producing a non-specific inflammation or non-specific wound at the site of penetration, and they are going to just lie dormant in that area. For example, if this was the penetrating site, they can for weeks or months just roam about in this area, and they are just going to, or they can just stay at one point and they can lie there for weeks or months. So the first scenario is that they penetrate the skin and they just lie over here dormant, they don't move from this point. Then it can also start moving, and it can start creeping at a very, very small pace in the skin, and it will produce these snake-like tracks, and they are slightly raised pink tracks, and they cause intense itching. And but the pace at which they travel, these are very, very very slow, and within a few days or a few months, they are going to wander about in this area only, and they are going to die off. So Humans, in case of Ankylostoma brasiliensis and the caninum, they are the accidental hosts, and they do not allow this parasite, or the parasite cannot go any further beyond the point of penetration, and it just produces these small raised lines where it is moving about, and this is known as creeping eruption. And this is a short essay question in case of parasitology, and it has come in your past papers as well, and it is also asked very commonly in your viva. Again, this is a picture of the creeping eruption. So you see, it just ends over here, it doesn't go any further. So it's, since it is just aimlessly wandering about in the skin, it is going to produce this red itchy line, and which indicates that it is some parasitic infection produced by a worm which is not pathogenic to human beings. Any questions till this point? Anything which you would like to ask? Okay, so let's continue with the next one, and this is known as Riccanculus medinensis. Riccanculus medinensis causes a disease which is known as riccanculiasis. Riccanculiasis. And the other common names of these worms are the guinea worm, serpent worm, or the Medina worm. Medina worm from the place Medina, because it's very common in that area. At one time, it was very common in that area. Geographically, it has predominantly Africa, also in India, Pakistan, Saudi Arabia, and Yemen. And basically, it is found in areas where you have the freshwater lakes and rivers. But over the years, the controlled measures, epidemiological measures, has brought the incidence of the disease down to a minimum. And in certain parts of the world, it has been totally eradicated as well. Habitat is the adult female is found in the subcutaneous tissue, especially of the legs, arms, and the back. And these are those areas which come into contact with the water. And anything which is coming in contact with the water, the adult female can penetrate that area. And then the definitive host is man, and the intermediate host is this cyclops, and it is a type of a fresh water fish. Adult female is the largest nematode of man, and it may measure as long as 1 meter. It is slender, milky white. It has an anterior end which is rounded, and the posterior end is tapering. This is your female, and this is the male, and the adult is smaller, and it is rarely seen. So when you take out this worm, it can be as long, if you just see like the bunch of worm which is seen in this picture. Embryos, they are the larval forms, and these are coiled, with an anterior end is round and the posterior end is tapered, and about 500 to 750 micrometers in length. Now the life cycle. Contamination occurs, or the infection occurs, because of humans drinking water which contains the copepeds, which are infected with the larvae. So cyclops, which are infected with the larval forms, if they are present in the water which we drink, these cyclops, they will release these larvae when they go into the stomach, and then the larvae are going to penetrate the host stomach. They are going to pass from the stomach into the intestines. They are going to penetrate the intestinal wall. They are going to mature, and they are going to start reproducing over there. So the fertilized female is going to migrate to the surface of the skin, and it is going to cause a blister over that place, then it is going to discharge the larvae, and these larvae, they are released into the water from the emerging female worm. So basically what happens is that you have these larval forms which are known as the L1 larvae, and they are going to be released into the water. So survival of the larva is if they are released into the water, or ye female jo hai, it is generally on those areas which tend to come into contact with the water. So जैसे I told you before, the back इसलिए कि in the olden days जो water carriers थे, आप अगर आपने सुना होगा वो मशकीज़ा जो कि एक चमड़े का एक थैला होता था जिसके अंदर पानी भर के एक जगह से दूसरी जगह लेके जाते थे, तो उस मशकीज़े में से जनरली वाटर ooze आउट करता था, क्योंकि लेदर इज नॉट समथिंग विच इज गोइंग, इट्स वाटर प्रूफ, बट उस तरह से वाटर प्रूफ नहीं होता था कि उसमें से पानी ooze आउट ना करे, तो वो पानी उनकी बैक्स पे थोड़ा करके लगा रहता था, एंड दैट बिकेम एन एरिया विच वाज मॉइस्ट, विच हैड वाटर. सो बैक वाज आल्सो वन एरिया जहां पे ये अडल्ट फीमेल जो है in anticipation of the water, it could go there. या फिर hands, and but most common site was the feet, because the feet come into contact with water most of the time. So this फीमेल आफ्टर माइग्रेशन थ्रू द स्किन, इट गोज इनटू एन एरिया, और वहां पे वो स्किन को अपने टॉक्सिन्स प्रोड्यूस करके, एक ब्लिस्टर प्रोड्यूस करके, अपना एक छोटा सा मुंह निकाल के वहां बैठ जाता है. एंड वंस इट इज सिटिंग ओवर देयर लाइक दिस, देन as soon as it comes into contact with the water, उसकी जो लावे हैं वो बाहर निकलने शुरू हो जाते हैं. एंड these larvae, these are the L1 form of larvae, and in the water they are going to be, these larvae, they are going to be taken up by the cyclops. Cyclops में उसकी further development hoti hai. It goes through stages of molting, and 2 molts take place, and 3 larvae they are produced. जब वो 2 molting के बाद जो larva form होता है, this larval form in a cyclops is going to be infective to man. ठीक है, L2 या उससे पहले, even if they are taken by the human beings in the infected water, they are going to be destroyed by the acid of the stomach, and they will not reach the intestines. But जब L3 वाले होते हैं, L3 wale, they are able to survive. So when the water is when we drink water which contains these cyclops, this water will go into the stomach. The stomach acidity से cyclops digest हो जाएगा. Larval forms resist होते हैं इस acid को. They will survive. They will go down into the intestines. Intestines में वो male और female worms produce करते हैं. Male mate करेगा with the female worm, and then it is either going to die off or something. And this female worm is then going to start penetrating various structures, and then it's finally going to come into the skin, and skin ko wo travel karte karte it is going to come into the surface, which is going to come into contact with the water, और फिर वो life cycle उसकी repeat हो जाएगी. Okay, so the infection is caused by ingestion of water which is contaminated with cyclops infected with the larva. And the first larva is again the rhabditiform larva. It is going to penetrate the human digestive wall. It is going to lodge in the loose connective tissue and mature into the adult form in 10 to 12 weeks. Okay, so the larval form goes into the connective tissue wahan pe in 10 to 12 days, 10 to 12 weeks, which means about 3 months, it is going to develop into the mature adult form. And then it is going to develop further, and it is going to remain there, and in about a year, क्योंकि उसकी migration बहुत slow होती है, it is not going to travel fast, and within 15 minutes or within 10 minutes it's going to travel from one place in the body to the other. Very slow migration, and it migrates to the subcutaneous tissue, which come into contact with the water and discharges its larvae into the water, and these are then taken up by the cyclops जहाँ उसकी further development होती है. So just see this कि females they are going to migrate into the skin. ये उसकी skin में migrate करते हैं. जैसे ही पानी उसमें जैसे ही क्या कहते हैं ये माइग्रेट करते हैं, एंड वैसे as soon as it comes into contact with the water, these are the larval forms which are going to be released, and this is then going to be taken up by the cyclops. So अगर transmission को हमने रोकना है, so we need to have different types. We need to have, one is the health education, and number 2 is we need to decontaminate the water. We need to protect the water sources. So basically the contamination is, the transmission is through the fecal-oral route. It's rather not the fecal-oral, it is through the oral route, because अपने स्किन में से ये पानी में जाती है, और पानी जो है is taken up by the individuals, and contaminated water is the source of infection. Clinical features include localized, mostly they are localized, and but they are so painful and so um, debilitating that the individual's normal life activities, they are going to be disrupted. In the superficial tissue, when it comes to this area, it is going to release certain toxins, and these toxins produce a local inflammatory reaction, and this is going to result in the form of a blister, and this blister is going to contain a serous fluid. This serous fluid does not contain any bacteria or any other infectious particle. This is a sterile blister, and it is just going to have the female worm, and this blister is then going to burst, and this thread-like structure which you can see over here, this is the whitish filament of the Recanculus medinensis worm, and it is going to stay here, and it takes about 1 to 3 weeks to for this in the to emerge. And in 1 to 3 weeks time, it is going to make this blister, it is going to burst that blister, and then it is going to start protruding itself out of that blister which it has formed, or out of that pinpoint hole which it has formed. And this ulcer is very, very painful, and it is also accompanied by inflammation. As you can see, there is swelling of the foot, and there is so much pain in this condition that the patient is unable to walk. Coming to the lab diagnosis. The first thing is to the detection of the adult worm, which can either be seen at the surface. When you examine the foot, you might be able to see the white thread-like structure coming out of the ulcer. And if you can't see that, if you just have that swelling and a blister over there, and the history is suggestive of a nematode infection, then you can carry out an X-ray, and these worms, they can be seen as long thread-like structures on an X-ray picture. You see a match over here, and you must be wondering why this match is over here. It's not to make a picture. This is one of the procedures for the treatment of this parasite. How? अगर इसको forceps के साथ या किसी और चीज के साथ निकालने की कोशिश करते हैं, तो then this thread is going to break, and as soon as the this thread is going to break, it is going to result in a toxic reaction, toxic allergic reaction, क्योंकि उसके सारे toxins जो हैं वो वहाँ पे release हो जाएंगे because of the breaking up of the parasite, and then the patient can either have a localized anaphylactic reaction, या उसको अगर वो absorb हो जाता है circulation में, तो it can result in a systemic anaphylactic reaction as well, which can be fatal for the individual. So जब भी हम Recanculus medinensis की बात करते हैं, we and उसकी diagnosis की बात करते हैं, and this type of a picture या उसकी removal की बात करते हैं, तो generally इसको students जो हैं वो कहते हैं कि जी बस you can just remove it with the help of a forceps, or you can remove it like that, but this is incorrect, and ये चूंकि and you do not need to pull on that. एक pencil या ये जिस तरह से matchstick है ये लेके, you just wind the portion of the parasite which is visible, and you just wind it over that matchstick and just leave it over there. The next day, or in a day or two, more of the parasite or the worm will have come out voluntarily. ये क्योंकि खुद थोड़ी थोड़ी इसकी emergence होती रहती है parasite की, it keeps on coming out. So जितना आप उसको वाउंड अप कर लेते हैं, उसके बाद नेक्स्ट स्टेज उसकी फिर थोड़ी सी और अंदर से जो है वो निकल आएगी. सो विदाउट पुशिंग, विदाउट टगिंग, विदाउट उसको खींचे, आपका जो ये वर्म है वो ग्रेजुअली ओवर अ पीरियड ऑफ अ वीक और 10 डेज, जितना भी टाइम लगता है, वो ग्रेजुअली इसको वाउंड करके तो इसको बॉडी में से निकाला जाता है, सो दैट नो टॉक्सिक रिएक्शन और एनाफिलेक्टिक रिएक्शन कैन टेक प्लेस. Then number 2 is the detection of the embryos. Secondly, हम ये करते हैं कि ये जो हमें वर्म नजर आ रहा होता है और ये फुट नजर आ रहा होता है, इसको हम एक टब में पानी लेके, तो उस टब के अंदर उस फुट को we immerse the foot in, पानी जो है ना उसके अंदर ये पाँव डाल के बैठ जाता है बंदा. what happens is that the worm, or whenever it comes into contact with the water, it is going to discharge its embryo. So as soon as it comes in contact with the water, the larvae are going to be discharged. Water is collected, and then you examine the water microscopically for the embryos. This forms the second evidence for the detection of the Dracunculus medinensis. Then third is the immunological test like ELISA and fluorescence antibody test. You can carry out an intradermal skin test, which produces a wheal in 24 hours. And the non-specific test is the blood examination, which will give you an eosinophilia. Uh, any questions? I didn't have anything inside. Yes, the blister is sterile. Sterile का बेटा मतलब ये होता है कि उसमें कोई bacterial infection नहीं है. Sterile का मतलब ये कि it is free of all infectious particles. ठीक है? And the initially blister sterile होता है, और जब उसके बाद जब worm जो है उसको sorry इनिशियली जो ब्लिस्टर है वो स्टेराइल ही होता है, ठीक है। और जब तक चूंकि उसके सबक्यूटेनियस टिश्यू में फीमेल वर्म is sitting there in the subcutaneous tissue, it is producing all that toxins, as a result of which that blister is formed. But ultimately when the female tries to come out, तो उसके बाद वो ब्लिस्टर जो है बर्स्ट हो जाता है, ठीक है। एंड वंस इट हैज बर्स्ट एंड इट हैज कम इनटू कांटेक्ट विद द आउटसाइड एनवायरनमेंट, तो देन चांसेस ऑफ अ बैक्टीरियल इन्फेक्शन आर देयर। एंड ब्लिस्टर इनिशियली जब तक वो इंटैक्ट होता है तब तक वो स्टेराइल ही होता है, और उसके अंदर कुछ नहीं होता एक्सेप्ट द फ्लूइड which is being generated because of the toxins which are being produced by the female Dracunculus medinensis worm. लेकिन it cannot, the blister cannot remain there, and the female cannot remain there for an indefinite period of time. After some time उसने उस blister को फाड़ के बाहर निकलना ही निकलना है, so that its life cycle can continue. So when that happens, the blister changes into an ulcer, और जब वो अल्सर बनता है तो उसके बाद तो फिर उसके अंदर एक बैक्टीरियल इन्फेक्शन हो सकती है। Okay, so this is a picture of the Dracunculus medinensis worm collected from a patient. और आप ये देख, just I put up this picture just to show you, so that you can remember it is the longest nematode which you will encounter, because इस तरह के questions आते हैं, longest nematode कौन सा है, smallest कौन सा है, shortest कौन सा है, ठीक है। Any questions? Okay, so let's finish with the rest of the topic which is left, and that is the tissue nematodes. Tissue nematodes are various types, and what condition they produce is that is known as the filariasis. The disease which they produce is collectively known as filariasis. Most of the time, if you see the past papers, you generally get MCQs on this portion of parasitology, but you also may get a question on one of them, most commonly Wuchereria. So I'll briefly go through this topic, and then we will be finished with the parasitology curriculum. So classification of these human filarial worms are they can be subdivided into three different broad groups. Number one is the lymphatic filariasis, which are those parasites which are going to cause the infection in the lymphatic channels. Then there are the subcutaneous filariasis, which are going to cause infection in the subcutaneous tissues, and then the serous cavity filariasis, and basically these are non-pathogenic for human beings. So most important is the lymphatic filariasis, in which we have the Wuchereria bancrofti and Brugia malaya. And then we have the subcutaneous, in which we have the Lualoa, which causes swelling in the subcutaneous tissues, and then we have the Onchocerca volvulus, and this causes a disease most commonly which is known as the river blindness and dermatitis. And then we have the Manzanella streptocerca, which is causing the skin disease. And these two, serous cavity filariasis, they generally do not cause disease in human beings. So we'll study, just as a prototype, we will study the Wuchereria bancrofti, which is the most important. Adult worms are, in case of Wuchereria bancrofti, this is the male, and this is the female, and this is the microfilary, or the larval form of the parasite. This will help you in remembering the different types, the different names, as well as the habitat and the vectors which are associated with these parasites. The nematode which we are talking about is the Wuchereria bancrofti and the Brucia and Malaya, and these two are most important. And they are going to be found in the lymphatic tissue. The adults are going to be found into the lymphatic tissue, whereas the microfilary, the larval form in case of the of these worms, they are known as the microfilary, and these are going to be found in the blood. And therefore, when we are looking for the diagnosis of these infections, we are going to carry out the examination of the blood for the presence of the microfilary. Vector is the Culex, Anopheles, or the Aedes species. In case of Wuchereria, similarly, in case of the Brucia, it can be Anopheles or it can be the Coculatidia. So these are basically the mosquitoes which are going to be responsible for the transmission of the Wuchereria and the Brucia malae. Then we have the microfilary. Where are they going to be present? These microfilary are generally going to be present in the blood periodically, or they may be present during the evenings. Then we have the subcutaneous filariasis, in which we have the loa, and the adults are going to be found in the subcutaneous tissue, or they may be found in the conjunctiva. And the microfilary would be found in the blood, and over here the vector is the deer fly. Then Onchocerca volvulus, which again is in the subcutaneous tissue. The microfilary may be found in the skin and in the eye, and the black fly is the vector. Manzanella subcutaneous tissue found in the microfilary are found in the skin, and then these are the small sorts of insects, as vectors are the midgets, and this is going to be responsible for the transmission of the disease. A few words about Wuchereria bancrofti. The mode of infection is the mosquito bite, so it becomes the inoculative method, and the transmission is through the female mosquito, Culex, Aedes, and the Anopheles mosquito. In India, it is generally the Culex species which is going to be responsible. Infective form is the third stage larva, and portal of entry is through the bites of the mosquito, so it is the skin, and then from the skin it is going to go and localize into the lymphatic system, and its incubation period is about 8 to 12 months. It's a very long incubation period. Then we have the life cycle of Wuchereria, and Wuchereria mosquito takes a blood meal, and the larval forms which are present in the human, they are going to be injected into the skin. So the mosquito is going to take a blood meal. During its ingestion, it is going to deposit the L3 larva, which is present within its saliva, and it is going to inject them into the skin. And in the subcutaneous tissues, these are then going to go into the lymphatic channels, where the adult female and male worms, they are going to be produced, and these adults are then going to mate, and they are going to produce the microfilary, and these microfilary migrate into the lymph and the blood channels. And when you carry out a peripheral blood film examination, or you carry out the examination of the lymph node, which is swollen at times, you can see these microfilary, which have and the diagnostic feature is that they have a sheath around them. Sheath is a covering. किसी भी चीज के, जैसे आपने फॉर एग्जांपल कोट है, कोट के ऊपर जब आप इसको टांगते हो फॉर द विंटर्स या उसको स्टोर करते हो, तो उसको अपने कोट को आप एक कोट के कवरिंग में, उसके अंदर प्लास्टिक की कवरिंग में डाल के तो फिर आप रखते हो ताकि वो प्रोटेक्टिव रहे. सिमिलरली दीज माइक्रोफिलेरी दे हैव ए covering around them which is known as the sheath, and these are then going to migrate into the lymph nodes and into the channels, or when the mosquito is taking a blood meal, so it is going to take up these microfilariae as well. And these microfilariae, they are going to, in within the body of this mosquito, they are going to shed off their microsheath, they are going to shed off their sheath, and then they are going to go into the midgut and then into the thoracic muscles जहाँ पे इसके different larval forms develop होंगे. And finally L3 larva जब बन जाता है, and this is now occurring in the thoracic muscles of the mosquito. When it is going to develop the L3 larva, this is then going to go into the mouth of the mosquito, or mosquito का जब saliva में जब whenever it is, and it's in the proboscis of the mosquito. ठीक है, proboscis उसका वो जो लंबा सा उसकी pointed nose होती है, या कह लो pointed mouth है, by means of which it is going to puncture the skin, और उसी के अंदर उसका saliva आता है. When it is taking up the blood meal, it is also injecting the saliva into the skin. So it is then in that saliva, since these larvae are going to be present, it is going to deposit those larvae into the skin, and from there the cycle is going to be repeated. Clear? Manifestations clinically, it can produce two types of disease. Number one is an asymptomatic filariasis. इतना number ही नहीं है it is going to produce any signs and symptoms, so they are living within the human body without producing any marked inflammation or any marked signs and symptoms of the disease. Then we have the symptomatic filariasis. In that case, there can be two types of probabilities. Number one is that it can produce an inflammatory phase and it can produce an obstructive phase. Inflammatory phase उस situation में होगा जब number of parasites जो हैं वो कम होंगे, they are producing a localized inflammatory reaction at the place where they are sitting or in that adjoining area. Obstructive phase तब होगा when they are going to block the lymphatic channels, and when the lymphatic channels are blocked, the lymph will not be able to be drained, and उसके जो जहाँ पे भी ब्लॉकेज होगा उससे पीछे जो एरिया होगा वहां पे वो लिम्फ जो है वो कलेक्ट होना शुरू हो जाएगा, और उसकी वजह से वहां स्वेलिंग होगी, एंड देन इट बिकम्स एविडेंट कि इस पेशेंट को कोई प्रॉब्लम है. So here you have the inflammation and this is a lymphangitis. ठीक है, ये एक toxic reaction कह लो या immune इसका एक reaction है because of the presence of these parasites within the lymphatic channels. So this will be visible in the form of this reddening, inflammation on the surface of the skin, और वो lymph nodes जो हैं वो swollen होंगे in that area. But if there is a blockage, for this indicates that the blockage is somewhere over here. ठीक है, so जो lower area है that has become swollen with the accumulation of the lymph, and as a result of which ये सारा का सारा area जो है that has become this fluidy or swollen area. ठीक है, and this can become very very extensive. ये ऊपर तक जा सकता है और बॉडी के किसी भी पोर्शन को इन्फेक्ट कर सकते हैं. और अगर आपने एलिफेंटिएसिस का लफ्ज सुना होगा, look up Google elephantiasis, and this would be because of the lymphatic obstruction because of the microfilariae of the Wuchereria bancrofti. ठीक है, वो पूरी की पूरी legs जो है at times because of the, and this is very common in India, or because of the lack of education, lack of facilities, medical facilities, or lack of the ये लोगों के अंदर जो especially villages में रहते हैं, they keep on disregarding the condition, और वो वर्स से वर्स होती जाती है, और ये एक एक टांग जो है वो एक एक मन भर की जो है ना वो हो जाती है उनके ना. So look up elephantiasis and you can see those pictures in which these legs, they are, I don't know how many times the diameter of a normal leg. So coming to the lab diagnosis, we have the direct and indirect evidence. Direct evidence तभी मिल सकता है when we can see the microfilariae or the adult one. अब microfilariae जो है, you will need to see a sheathed microfilariae having a pointed tail tip free of any nuclei, and this can be seen in the peripheral blood, This can be seen in the chylous urine, because जब lymphatic channels block होते हैं या lymphatic channels में overproduction होती है lymph की, तो that lymph starts going towards the bladder, और वहाँ पे वो urine के अंदर mix होना शुरू हो जाता है, उसको हम chylous urine कहते हैं. So in urine examination, if you find the lymph and if you find the microfilari, that can be a direct evidence of the presence of the disease. फिर जो lymph चैनल्स हैं या लिम्फ की वो वेरिसेस बनी हुई हैं, उनको अगर आप एग्जामिन करते हैं, उनमें से फ्लूइड लेके आप एग्जामिन करते हैं, वो दैट कैन हैव द माइक्रोफ्लेरी, और इट कैन आल्सो प्रोड्यूस अ हाइड्रोसील. हाइड्रोसील जो है द सेम process, but वो जो lymphatic channels which are draining the scrotal area, वो अगर block हो जाते हैं, तो then there will be accumulation in that area, in the spermatic cord, in the testes, वो उसको hydrocele कहते हैं. ठीक है. सो एनीथिंग विच इज बीइंग ब्लॉक्ड बाय द जहां जहां आपको लिम्फेटिक चैनल्स नजर आते हैं, पेरिफेरल ब्लड नजर आता है, उसका जब आपका फ्लूइड का एग्जामिनेशन करते हैं, यू मे बी एबल टू सी द माइक्रोफिलेरी. नंबर 2 इज द अडल्ट, एंड इफ यू हैव अ lymph node biopsy, you can see the adult, or you can see the calcified worm by the x-ray. ठीक है. But basically the microfilari are the forms which are producing the manifestations of the disease, and they are the forms which are going to be responsible for the which are going to help us in the diagnosis. Adults जो हैं, they are generally, even if they are present in the lymph nodes, they may be present in a very few percentage of the people, yeah, and most of the time they are dead and they can be catched up on the x-ray. ठीक है. Indirect evidence is the allergic test, like the blood examination for eosinophilia and the intradermal test, which will produce a wheal after 30 minutes. Then the immunological test, like the demonstration of the antibody to the filarial antigens, and the demonstration of the filarial antigens in the blood. So this was all about the tissue nematodes. बाकी book में आपके the lymph is going to accumulate because the vessel is going to be blocked because of the presence of these microfilari. Okay? The presence of the microfilari within the lymph channels, they are going to, as their number is going to increase, or because they are going to move from one place to the other, they are going to produce an inflammatory reaction. And naturally the body inflammatory reaction to body ही produce करती है ना, and the body का inflammatory reaction इस वजह से हो रहा है because there is a foreign antigen. लेकिन अगर blockage होगी because of the presence of a large number of microfilari, तो तब उसकी वजह से जो lymphangitis is more likely to occur because of the inflammatory reaction of the body, and the lymph जो filariasis है या lymphatic obstruction, that is because of the presence of these parasites causing an obstruction in that area. Questions? They do not enter the blood vessels. They have they enter only the इनका जो है ना, they are going to remain in the lymphatic channels, and they have a certain period. I didn't go into the details, लेकिन इनका एक periodic time होता है जबकि वो blood के अंदर आते हैं. Some of them have that periodic time at night. Most of them, वो शरीरिया का जो microfilari है, that remains in the lymphatic channels. रात के time पे whatever the signal is, I don't know, it is still probably being discovered. Lekin they tend to migrate from the lymphatic channels into the bloodstream. Wahan pe probably they are taking up nutrition or whatever is the reason, and then during the night, after some time, they again come back into the lymphatic channels. So they are not remaining within the blood vessels, and they are not blocking the small blood vessels. So stroke or MI नहीं होता, but बेसिक उनका जो प्लेस ऑफ रेजिडेंस है, दैट इज, यू कैन कॉल दैट इज द लिम्फेटिक चैनल्स. वो लिम्फ नोड्स में रहते हैं, लिम्फेटिक चैनल्स में चलते फिरते रहते हैं. रात के टाइम पे थोड़ी देर के लिए सैर करने के लिए वो ब्लड में आती हैं, पेरिफेरल ब्लड में आती हैं, और उसके बाद फिर वो ब्लड चैनल से वापस अपने घर को चले जाते हैं, व्हिच इज द लिम्फेटिक चैनल्स. दिस इज हाउ इट इज. एनी अदर क्वेश्चंस?
So this completes our parasitology today. So inshallah, if you have any questions, next time we'll meet next week. We'll start with the mycology, and I'll be taking the lecture on introduction of mycology. So till that time, take care of yourselves. If you have any questions, you know where to reach me, you know where to put up your questions, and I'll be waiting for your questions. Thank you everyone. Take care. Stay safe.